and welcome to another lecture. And today we will be discussing something about intrapartum and the fetal assessment. That the the topics that are important and that things that you need to know as a pediatrician or a neonatologist. So, what should you know about the intrauterine and intrapartum monitoring of the fetus? So, majority of the insult that occurs to the newborn, majority of insults that occur to the newborn in the form of hypoxic ischemic encephalopathy, majority of them are peripartum. They are not postpartum, they are peripartum, or they can be antepartum. So, it is the ongoing things that might have occurred before the birth that might be the main factor leading to birth asphyxia or even the hypoxic ischemic encephalopathy. So there are some major means of antepartum assessment. So what are those? So first is fetal movement. If there is fetal movement, you can definitely or very safely say that, okay, the fetus is fine. Obviously, fetus that is not alive or passed away, or it might be IUFD, obviously that fetus will not be moving. Now, how to see the fetus movement? So there are two ways. One is the mother's perception, that mother is telling that the fetus is moving inside, mother's perception. A majority of IUFD might come to you that the mother is not feeling like till yesterday or till 2 days ago, that mother was able to feel the movement. Since last some time the mother is not able to feel that the fetus is moving inside. So the mother's perception is an important a marker. Second is a real-time USG, that you do USG and you see the fetus moving inside. If you might be going in more detail, then obviously you can see the cardiac activity that is there, fetal echo. So, real-time USG can be done. Okay. Next is FHR, fetal heart rate. Very, very important. The thing that you might be seeing, the FHR monitors that might be seeing, if you are an intern, I guess, you have one job in labor room, that you have to, do the FHR monitoring of each and every, mother who is, in labor. So FHR might be, assuring, or FHRs might be reassuring, or might be, ominous. So you'll be seeing the interpretation of FHR, but FHR can be a part of NST, non-stress test, and it might be a part of contraction stress test. So as the name suggests, in non-stress test, you are not giving any extra stress from outside, like, oxytocin or nipple stimulation, where you are stimulating the child or the fetus by stimulation or, release of oxytocin, which might lead to the contraction, and the response of fetal heart rate to the contractions that are occurring is the important thing in FHR. Next is fetal biophysical profile, also known as Manning score. Manning score is a comprehensive score which has 5 constituents that we will be seeing in detail in today's lecture. That what are they? And they are usually seen. Initially, non-stress test was the first thing, that, okay, if fetal movement is not the list I'm making is in the way that you have to approach. So first is that fetal movement agar feel nahi ho rahi hai and mother is saying the fetal movement is not there, then you can go for FHR monitoring via non-stress test. If that doesn't work, obviously contraction stress test is not used nowadays, and next you go for biophysical profile, also known as Manning score. Okay, and then you might go for the 2 other things. One is the fetal growth. Fetal growth can be seen with the USG, and second is the fetal Doppler. So fetal Doppler, or the blood flow velocity, can be done of multiple vessels, be it umbilical artery, be it umbilical vein, and one of the other most common is MCA. So 3 important Dopplers that I have talked about. So this 5 things we'll be discussing today. This is how we will approach, and this is how you have to approach. So first is fetal movement. Fetal movement. So first thing you should know that obviously fetus is just like a neonate, that it sleeps majority of the time, and it is a good indicator that if the fetal movement is there, it is a good indicator of the well-being of the fetus. Okay, and it can be seen by the tocodynometer. Tocodynometer. There are electromagnetic devices, electromechanical devices which detect, the current that is created due to the mechanical activity. Now, fetal movements are very variable and they have a poor predictive value because, see, sometimes, like majority of the times, the fetus is in active sleep. Active sleep is the most common state that the newborn, the fetus is in, followed by a quiet sleep or a deep sleep. Okay, very rarely you will see a waking state fetus. Fetus is usually not in waking state. It is rare. It is rare, though it is not, never seen, or though it is not common. Active sleep is the most common. Obviously, during that time, you might not feel a movement. So that 24-hour movements you can see, like many of the a crude test that can be used is कि भाई मम्मी को पूछो कि last 24 hours में how many kicks or how many movements have you felt. So it is a good crude test, but it is not 100% or even not 50% reliable for that matter. Okay, so this is very, very important. And there are some maturational changes that the maternal perception, by the name of quickening, maternal perception usually of the fetal movements occurs at approximately 16 weeks. Approx 16 weeks pe mother starts to perceive the fetal movements. USG obviously detects movement as early as 2 months of post-menstrual age, as early as 8 weeks, but uska double time mein mother starts to perceive a good amount of movements. Okay, so this is very, very important. Now this movements have a specific flow. Okay, movements have a specific flow that will be seen. So see, ये gestation age हो गया, movements versus gestational age, movement versus gestational age. So obviously it would begin, the movement would begin at 16 weeks. Okay, it begins at 16 weeks and then it peaks or plateaus at 26 weeks. Okay, the movement peaks and plateaus at 26 weeks, then it suddenly abruptly falls, and then there is a second peak that is achieved at around 34 weeks, like between 32 to 36 weeks. So there is one abrupt fall that is seen, and then there are two plateaus. There are two peaks, there are two plateaus that you need to understand. There are two peaks. Okay, so this is very, very important, and this is what you should know. Okay, now there are some insults or exposures that might lead to change in this. So we will see the insult, we will see its effect on movements, we will see its effect on breathing, and we'll see its effect on behavior. Okay, so the insult might be something like oligohydroamnios. Now in oligohydroamnios, the movement's amplitude, the amplitude of the movement is less and the movement is slow. Okay, breathing might, the breaths or the breaths that you might see on the USG might be lesser. So this is what is seen with oligo. Behavioral changes are usually not observed with oligohydroamnios. Now, when you have a IUGR baby, intrauterine growth retarded baby, usually the amplitude is again less. Okay, the movements are decreased. Obviously, the movements are decreased and amplitude is less, along with decrease in breathing movements, and the behavior is delayed. Obviously, as you know, that IUGR occurs due to an insult, be it genetic or be it antepartum. So that is very, very important that you should understand that IUGR has long-term complications that sometimes you miss, and you all might know about this Barker's hypothesis that you probably might have missed it. So Barker's hypothesis says that IUGR babies have higher risk of developing chronic problems later on their life, be it diabetes, be it asthma, all that. So that is very, very important. Next is nicotine, maternal exposure of nicotine. Obviously, I am writing about maternal exposure nicotine. Obviously, fetus को कोई nicotine नहीं देगा. So, maternal nicotine exposure will temporarily decrease the movements, but later on, obviously, it might compensate and be normal. Okay, breathing is decreased, and behavior actually shows a prolonged state. Okay, prolonged state of disorganization might be seen with nicotine exposure. Obviously, nicotine exposure will cause vasoconstriction of umbilical artery and umbilical vein, and it might at the end lead to a IUGR fetus that is having probably this abstinence, some variant of neonatal abstinence syndrome. Next is maternal cocaine. Again, it is a worse variant of nicotine. Same vasoconstriction will happen. But cocaine is a very strong stimulant compared to nicotine. So the movements will increase. The breathing is disorganized and altered, and the movements are also disorganized. Okay, the child is obviously getting stimulated. Steroids is very, very important. Steroids temporarily for 1 to 3 days decreases the fetal movement. Okay, steroid decreases movement and breathing for 1 to 3 days, and there is loss of diurnal variation. Okay, obviously, see, it is said that more fetal movements are felt during the night compared to the day. Now you will ask why. Obviously, during the day when the mother will be moving around, the amniotic the amniotic fluid that is around the baby will, the movement will give it a rhythmic jula like effect, like, the rhythmic the stimulation that we give ke bachche ko jhula de diya, or you have put the baby to swing. Those when the mother moves, it provides a very smooth or rhythmic or a calming or a soothing effect. That is when the baby sleeps, and obviously when the mother sleeps at night, this movement is lost, so baby wakes up and starts to kick around. So that is very, very important. Okay, now next is FHR. So for FHR, first thing that we talked about was NST, non-stress test. Now, in non-stress test, what do we do is that we check for acceleration of fetal heart rate, acceleration of fetal heart rate. Now, what is acceleration? So there is increase of more than 15 beats per minute for at least more than or equal to 15 seconds. सो 15 बीट से ज्यादा 15 सेकंड के लिए हार्ट रेट न्यूबॉर्न का फीटस का बढ़ जाता है, एंड दैट इज नोन एज अ reactive NST. Okay, reactive NST. So what here is happening is that you either, you are doing nothing, you are just standing and you are observing the baby for around 40 minutes. 40 minutes is an arbitrary cutoff that they have taken. 40 minutes, you wait and see, and if you are feeling this acceleration, at least 2 accelerations that are felt in around 40 minutes without any stimulation. Okay, so more than 2 acceleration in a time period of 40 minutes, or you either give stimulation in the form of vibroacoustic or vibroacoustic stimuli. Okay, so that you can give music baja diya, ya the obviously it is not recommended, but you are not giving oxytocin, or you are not stimulating any contractions, just the fetal reaction you are seeing. Okay, and if this is not achieved, this 15 beats per minute for more than or equal to 15 seconds, 2 acceleration in 40 minutes are not seen, then you can say that it is a non-reactive NST. Now, obviously, there are multiple predictors or confounders that might be seen. कि भाई baby so raha hai, baby is not getting stimulated, or there are the baby has, or the mother has taken depressant in any form, benzodiazepine or alcohol. So multiple things might be going on. So the predictive value of NST for fetal distress in a reactive patient, like reactive NST hai, to kitne percent chance hoga that the patient might have fetal distress. So in a patient with reactive NST, what is the chance of baby having fetal distress? It is less than 1%. Okay, but in non-reactive NST, like the patient's NST is normal, what percentage of patients would be suffering from fetal distress? It is around not less than around 10 to 20%. Some studies have shown as high as 20%. The single best value, it is 20. So it is having a good negative predictive value per se, but not a very good positive predictive value if it is non-reactive. Okay, so very, very important. NST is again of a less value in less than 32 weeks because the baby is spending most of the time sleeping. So, if you probably will not just find reactions in the less than 32 weeker. The next test that was previously done was contraction stress test, where they actually induced the contractions of the uterus. And due to contraction of uterus, you see that how the fetus responds to that. Now, how can you give contraction to the fetus or the uterine contraction? You can either administer oxytocin to the mother or you stimulate the nipple. Obviously, it will cause release of oxytocin. So at that point, when the uterine contractions are there, you will see what is the reaction of the baby. So there are 3 results of a contraction stress test. So first test is positive, second is equivocal, and third is negative. And in positive CST, In positive CST, it might be reactive or non-reactive. Now, इस सब का मतलब क्या है? I will be explaining to you shortly. So, here when will you say that the stress test is negative? So matlab the fetus responded well. The fetus responded well to the contraction and there is no issue. Now positive test is actually considered as abnormal. Positive test is the one that is abnormal. Now positive test, what does positive test mean is that there are late deceleration. What is late deceleration? We will be seeing aage. The patterns of FHR will be seeing, but it is considered positive when you have a late deceleration over one or even multiple of contractions, and they can be accompanied by the accelerations also. So agar there is deceleration, late deceleration is a ominous sign. It is not a good sign. It means क्या हो रहा है कि भाई जब भी यूट्रस कॉन्ट्रैक्ट हो रहा है, the blood supply to the fetus is being cut off, and during that time the child is not responding very well to this contraction, and there is a reversal of blood flow to some degree, and the child is not reacting in a good way. There is some compromise that is there. Now, whenever you have a positive test, you call it reactive when there is associated acceleration also along with deceleration. कि भाई deceleration हुआ पर उसके बाद acceleration भी आ गया. So it is a reactive positive CST. In non-reactive, what is there? That there is no acceleration, only late decelerations are being seen. Only late deceleration aa raha hai, there is no acceleration that are seen, and only late decelerations are there. So this is very, very important, and this is what a non-reactive positive CST is. Negative stress test is that koi bhi, obviously negative stress test is there is no late deceleration. This is normal, no late deceleration. Now, what is equivocal is कि भाई late deceleration तो हो रहे, but they are non-persistent. Now, in positive, one more word that is important that you should know is persistent late deceleration. कि भाई वो late deceleration 15 seconds से ज़्यादा रह रहे हैं, they are persistent, they are happening again and again. They are not, came for 1 to 2 seconds and went away. It is staying for some time. So that is the importance of the positive test versus the equivocal test. Now, what is the predictive value? So predictive value is less than 1% of like predictive value for fetal distress, obviously same as NST. So predictive value for a positive test is less than 1%. The patient might have fetal distress, while it is 5 to 20% for positive test. Negative test पे आएगा because इसमें उल्टा है. Okay. Okay. So this is very, very important, but it is no longer performed in many places because again, oxytocin is their own set of side effects, and you are technically, causing the baby to, you are causing the baby stress. Obviously, you might be inducing some amount of distress yourself. So this is not outright used in many places. Now, biophysical profile, also known as Manning score. Now, this Manning score has 5 components, as I told you. So first is FHR reactivity. Second is fetal breathing pattern. के भाई सांस ले रहा है कि नहीं. Okay, diaphragmatic movements might also be observed after 20 weeks. So fetal breathing है. फिर gross body movements. कि बच्चा हिल रहा है grossly. Okay. Fourth is tone. Fetal tone can be seen by the extensor flexor movements. Obviously, the child is in the position of generalized flexion. And amniotic fluid volume. So this is the Manning score, and it has 5 components, and each are scored as 0, 1, and 2. Okay, 0, 1, and 2. And if depending upon the score, we will be seeing that what is the outcome that you have to go for. So this is very, very important that Manning score, though has a good predictive value, it technically does not define any criteria that इसके beyond ये profile अगर deteriorate होती है तो there will be a damage. You do not know the threshold beyond which the score deteriorates, that the patient will definitely have asphyxia, acidemia, or brain damage. So that is the limitation of this. Okay. Now, fetal heart rate the fetal heart rate variability or the FHR reactivity, that is the most sensitive to hypoxia or acidemia. See, it is the acidemia that is important in umbilical cord ABGA and not PCO2 or PO2, or even some to a degree lactate is also not very important. The most important component in umbilical artery ABG, arterial blood gas value, the most important factor is pH. Okay, so this is very very important that hypoxia acidemia सबसे पहले FHR को affect करते हैं, and the least affected is the fetal tone. The least affected is the fetal tone. Last to be affected is here. Now, the biophysical profile score and its interpretation, and what is the expected management. So 0/10 अगर आता है कि भाई सब डिटोरिएट हो गया है, it means it is a severe asphyxia. Severe asphyxia, and here you have to immediately deliver the baby. Immediate delivery is to be done, and preferably, or not preferably, actually immediate delivery by LSCS. This is one of the indication that you do LSCS, because immediately you do not have the time to, give the mother time for labor. Now, 2/10 is acute fetal asphyxia. Okay, there is acute fetal asphyxia, but there is a associated compensation. So there is a chronic compensation that is going on, and acute fetal asphyxia is there. Now here you can deliver for fetal indication, or if the child is having fetal distress, MSL ho gaya, so that all indications are there. So you can deliver for fetal indication. You're seeing cord around neck, loop of cord around neck. So then you can deliver for fetal indication. 4/10 is acute asphyxia. It is an acute asphyxia, and there might be some component of chronic asphyxia too. Now here mother indication is the important thing. कि भाई मम्मी का अगर indication है, then you decide that you deliver by LSCS or even normal delivery, depending upon the obstetrician's decision. And you have to closely monitor, because this patient can deteriorate acutely into 2/10 or 0/10. And obviously 10/10 has no evidence of asphyxia. And you do not have to do anything. You can just wait. Okay. So this is the interpretation of Manning score. Now, modified biophysical profile is also created, which has only two things. Okay. And it is NST and amniotic fluid index. Okay. Two things, NST and amniotic fluid index. Now, why these two words were used is NST is suggestive of an acute insult. NST abnormal, if it is there, it is suggestive of acute insult, while amniotic fluid index abnormality is suggestive of a chronic insult. So this is a very good modification, and it shows you if it is an acute insult, a chronic insult, or probably no insult. So this is very, very important that NST and AFI you can go for. Now, next is the fetal growth. I think that is IUGR के topics में we'll be discussing it separately. No need to get into them right now. Next, we will jump into the Doppler measurements. Doppler measurements. So 3 vessels measurements we are doing. 3 vessel measurements we are doing. And 3 vessels, the most important vessels or the most common is umbilical artery Doppler. Umbilical artery Doppler is very, very important, and it has 3 primary things that we go for. One is pulsatility index, second is a resistive index, and the umbilical artery flow Doppler. Okay, umbilical artery diastolic flow Doppler or umbilical artery flow Doppler. Okay, now pehle you have to understand that whenever you have conditions where villi are not properly developed, and there is increase in the resistance of the blood flow, it will lead to hypoperfusion of the baby, and it might lead to IUFD or even fetal distress. Now, PI was given by Gosling, okay, not Ryan Gosling, Gosling. And the resistive index was given by Perculot, okay. Perculot. Okay. Now, what is PI of Gosling? So it is peak systolic velocity, PSV, peak systolic velocity minus end diastolic velocity PSV minus EDV upon mean velocity. Okay, that is the perfusion index, while the resistive index is peak systolic velocity minus end diastolic velocity upon peak systolic velocity. So this is the difference, denominator दोनों में change होता है, but all in all what they say, what they indicate is the same thing. They are showing you what is the vascular resistance in the vessel. What is the vascular resistance? Now this is very, very important. And this is usually, this PI and RI are also commonly used for MCA Doppler also, middle cerebral artery Doppler. And obviously when you have a high velocity of MCA, there might be, a high output cardiac failure. While there is low velocity, you are having low output cardiac failure. Okay. So that is what RI and PI show. Now, this is usually what is Doppler finding in the normal patient. So, what is this suggestive is कि सिस्टोल में ब्लड जा रहा है, दिस इज द बेसलाइन, सिस्टोल में ब्लड जा रहा है और डायस्टोल में भी ब्लड थोड़ा सा जा रहा है, बट there is a constant unidirectional flow that is going on. So this is the normal Doppler of uterine artery कि भाई सिस्टोल में भी जा रहा है, सिस्टोल, दिस इज सिस्टोल, सिस्टोल में भी जा रहा है और डायस्टोल में भी ब्लड फ्लो हो रहा है. So obviously the values are different, but दोनों में blood flow हो रहा है. Now there is a abnormal variant of umbilical artery Doppler कि भाई सिर्फ सिस्टोल में blood flow हो रहा है, डायस्टोल में blood flow नहीं हो रहा है. ठीक है, डायस्टोल में there is absent end diastolic flow. Absent end diastolic flow is seen in these patient. इसका मतलब क्या है कि जब भी इतना हाई वास्कुलर रेजिस्टेंस है कि जब भी हार्ट स्टॉप्स टू कंट्रैक्ट, द ब्लड फ्लो स्टॉप्स फ्रॉम द मदर टू द फीटस और फ्रॉम द फीटस टू मदर. अम्बिलिकल आर्टरी का ले रहे हैं तो ऑब्वियसली इट विल बी देयर. ओके, नाउ नेक्स्ट इज रिवर्सल. अभी इसके अंदर क्या हो रहा है कि भाई डायस्टोल में उल्टी दिशा में ब्लड फ्लो हो रहा है. ओके, सो दिस इज एंड डायस्टोलिक फ्लो रिवर्सल and this is suggestive of absolute worsening of the patient. So a reversal of M diastolic flow is a very ominous sign and it is suggestive के भाई कुछ करना पड़ेगा. Okay, so it is a EDF reversal is a very ominous sign, that is C. Okay, now after this you can go for you can go for MCA, RI and PI obviously. And perfusion index usually जब decrease होता है, it is a protective mechanism कि भाई जो pressures है वो fall हो रहे हैं. So to some degree fall in perfusion index is protective, but एक point से beyond चला जाता है तो then you are missing the whole point and worsening is there. Okay, so this is about the the Doppler measurements in a child. I guess that's all for today, guys. We'll stop over here because थोड़ा ज़्यादा हो रहा है लंबा. And in the second part we will be covering the rest of the topics. So obviously आपको next class में हमको join करना है and I'll see you in the next one.